everybody calls everything an antibiotic, right? No matter if it's antiviral, if it's anti-this, if it's an anti-that, everything across the board is an antibiotic. Keep in mind with antibiotics, one thing is now we're thinking antibacterials, because you have to have a bacteria in order to have an antibacterial, okay? And so that's how you administer for those reasons. So, with infection-causing pathogens, you have your bacteria, your viruses, and your fungi. Keep in mind, your viruses are one of the toughest to get rid of. A lot of people who have viral infections take an antibiotic, right? And it's not going to touch it, and they still have symptoms a couple days later. Well, of course they do, because the anti-infective is not going to treat that virus, because again, it's got to be specific to those different cooties or microorganisms. So different classifications, either it's bacteriostatic or bactericidal. You could have ones that are both, or you can have either or. The static, the bacteriostatic, inhibits the growth of bacteria. So in the antivirals and in the antifungals, you'll see fungicidal or fungal static. And so again, static means it's inhibiting the growth of that bacteria. And then our bactericidal is killing that bacteria. It's also defined as broad spectrum or narrow. Narrow spectrum means that it's only a small window of what bacteria it can treat, or a broad spectrum meaning it's so broad or so widely spread that it can treat. So different classifications of the antibacterial worlds. So that just reinforces that. So the pharmacodynamics listed there, that's all the stuff that it does for functionality or function or action or however way you want to look at it. With antibacterials, body defenses. So bodies as a whole treat these specific bacteria. One is age. You have to think about those patients that have immature livers and immature kidneys. Who are they? Pediatrics, yep, infants, or children as a whole. What about the other age group that we worry about? Elderly, yep. Thinking about the elderly, they have slow functioning or immature functioning, or decreased in function is probably the better word to say it. Decreased function of the liver and kidneys, not to mention everything else. They're more susceptible to toxicity, things like that. Nutritional status. What is the best thing that we can give somebody who already has an infection to help that wound healing or healing as a whole? Protein. Protein is the best thing that we can give those patients when they have an infection or a wound per se. It's protein. To prevent infection, what can we give them? Vitamin C. Megadoses of vitamin C. Right? You guys take it too because you don't want to get sick. You'll see with finals, everybody gets sick during finals times, right? Because they don't get enough sleep, they're stressed. Vitamin C for nutritional. Immunoglobulins that are responsible for fighting this bacteria is IgG and IgM. IgG and IgM. Those are immunoglobulins that are responsible for the body's defenses. Circulation. When a patient has poor circulation, if you think about those patients, more than likely are probably diabetics, more likely have heart failure, more likely have hypertension, more likely have small vessel disease. So all these renal, don't forget the renal failure patients, could have liver failure. So all of thinking about them as a whole, their body's not circulating that blood as well. And so other things happen. So we need patients that have great circulation in order to help that body's defense against that bacteria. Who's the first attackers in the white blood cells when it comes to infection? Neutrophils. So they have to have strong neutrophils. So if there's any disease processes that are attacking those neutrophils, then there's a problem there. And then organ function, who we mentioned, immatures and those that are decreased in function. Resistance to antibacterials, natural or inherent resistance. That is without prior exposure to the antibacterial drugs. Without prior exposure. That's one natural or inherent resistance. Acquired resistance is prior exposure to antibacterials. Prior exposure. Book still uses the words nosocomial infection. We know that as healthcare acquired infections, or also known as HAIs. Healthcare acquired infection. That's where they don't have an infection when they get into the hospital. They get into the hospital and bam, they get an infection. Usually a lot it's post-surgical, or they come in and they're ambulatory, now they're sitting around immobile-wise, and now they get pneumonia. So that could be considered a nosocomial or healthcare-acquired infection. A lot of times with MRSA, VRE, Cinebacter, all the cooties that are out there, just to name a few, because there's many. Cross-resistance to antibacterials. One thing that we have to do when a patient has an infection, one, we have to know what is the microorganism or the cootie causing that infection. We do a culture and sensitivity. Whether that is a urine culture, a wound culture, a sputum culture, blood culture, we can culture just about anything. First, we have to culture it to see what the cootie is causing the infection, and then what is it resistant to. So I can go and give a broad spectrum antibiotic and hoping, but that broad spectrum antibiotic may not cover that bacteria. So then we have to find ones that the bacteria is sensitive to. That is why it's important to always do the culture and sensitivity prior to administering any anti-infective across the board, whether it's fungal, any of it. Anti-infectives as a whole. So culture and sensitivity. We do no good if we don't find out what the cootie is before we treat it. First and foremost, most definitely. Combinations of these antibacterials. They do not routinely prescribe combined antibacterials unless the infection is out of control and they have to get more on board. The goal is not to treat with more, because what happens later is the more that we expose patients to the antibacterials, the more resistant the cooties they get. And you guys understand that because think of MRSA. MRSA is methicillin resistant Staph aureus. It's resistant to psyllins, right? That's what the name of it is. So anything that ends in psyllin, which is in penicillin family, is not going to work on that MRSA. That's why there were so many outbreaks of it, because it's highly contagious, et cetera, et cetera. Then you've got to also think when we're talking anti-infectives, is a chain of infection, right? Hand washing, big popular thing now with the pandemic. But also about you have to have a host that is susceptible to receiving that cootie, and then any breaks in the chain, lack of sleep, stress, that kind of stuff. So when they do use the combination antibacterials, one thing is it's doubled. So it's an additive effect. They take the same thing of the same type and add it together. So there's an additive effect. Potentative, which is a funny word, is also a fancy way to say synergistic. Synergistic. So you know that it enhances something. Or it could be two antibacterials that are in the two different things that might enhance the other. And you'll see that a lot when we come and talk about like augmentin. Anybody have augmentin before? That's exactly what you have. It's the same type, even though you think it's additive, it actually enhances. The clav acid, it actually is enhanced by the moxicillin. So that's how that works. And then an antagonistic is acidyl and a static works together. That's a problem because it diminishes both as a whole. So we don't want to ever mix bacrostatic and acidyl together because they go, which one is going to work more? Like they have a fight with each other. Okay? General adverse reaction, self-explanatory, mild as a rash, severe as anaphylactic shock. We already know we treat anaphylactic shock with an antihistamine, epi, and bronchodilator. We already know that, so you guys are a step ahead of the game. Severe superinfections. We always forget about superinfections. Because if somebody has, let's say, bronchitis, they're taking this antibacterial, then they end up getting diarrhea. Diarrhea is considered a secondary infection to the diarrhea. Or they get a worse infection, is enhanced because it could be not resistant. So secondary infection kind of falls under that superinfection as a whole. So if you guys have ever taken an antibacterial and you get diarrhea, there's your superinfection now because it's gotten rid of that normal flora. So 2 things that patients can be, well, there's actually 3. 3 things we like non-pharmacological first and then pharmacological. What 3 things can a patient eat or take to help with that secondary or super infection? Probiotics is one, so that could be oral or beads. What else? Yogurt, and what else? There's one more type of food. Huh?
Fermented foods like
Yeah, but even better than that would be buttermilk. Buttermilk, now that I recommend everybody to have cheesecake, but buttermilk is found in cheesecake, especially if those patients are diabetics, we don't want them to, of course, expose themselves. So, but next time you eat cheesecake, you'll think buttermilk. So yes, yogurt, the probiotics, fermented foods as a whole, but yogurt actually is the best. Best thing besides the probiotics, of course, but we're talking non-pharmacological first. So it could take, actually, the antibacterial or the infection can be gone, but the diarrhea could linger, okay? So we have to make sure that we keep an eye on that. Especially the diarrhea leads to electrolyte imbalance. So when I say electrolyte imbalance, you're thinking decreased potassium. When you think decreased potassium, you're already thinking VTAC, 3 or more beats. When you think VTAC, you think lethal rhythm. That's where your mind should go. Because, they have diarrhea, no big deal. But it's what they're losing is the electrolytes and the food that's associated with that. Especially thinking about those elderly patients, right, who are more prone to dehydration. Now you're going to give them an antibiotic or an antibacterial, cause them diarrhea, and now it leads them to even worse case scenario of even more severe dehydration. So all that plays a role. When it comes to organ toxicity, antibacterials do not like livers, kidneys, or ears. Specifically, the family, the mycin, the suffix family, suffix is mycin, C-I-N. Mycin, you're going to see in a lot of subclasses. Keep in mind, those 3 organ toxicity is liver, kidneys, and ears. I'll point out the ones specifically that do irritate the ears. Any mycin has the opportunity to affect all 3. However, there's more that are more prone, I guess, for lack of a better word, that could cause problems with those. A narrow spectrum, broad spectrum, we already mentioned. So, getting into our first type of class of penicillin. Penicillin we know is one drug, but it actually is a class of itself that has its friends and family. The indencillin, C-I-L-L-I-N, as your suffix. I want you to pay attention to what the chemical structure is. We really don't talk about chemical structure a lot, but this is important when it comes to the penicillin family. Beta-lactam ring is actually the structure of penicillin. There's other drugs that you will see that are also made up, but they call them something different. They're still in the family of penicillin. So if a patient tells you that they're allergic to penicillin, we already know, we ask what reactions next, right? Then we could ask them, have they had any of the other family members like cephalosporins? They're going to probably tell you no. Because nobody wants to risk the chance of causing any kind of reaction to them by getting them the rest of the family. Does that make sense? Okay. So they won't know if they're allergic to the beta-lactase friends or family or the cephalosporins because nobody's tested the theory, which we don't want to throw them into full anaphylactic shock to do that. So basic penicillins tells you what they all do here. Let's review that. You notice it's narrow. And the one reason I want to point that out is penicillin has been around forever and a day, plus a day, and a week, and a month. So to get my point across, it's been here forever. So patients that are in their 80s, 90s have been exposed to penicillin. That's probably one of the first antibiotics or antibacterials they had. Now, they are resistant to any more penicillins. It's not going to work for them. That's why they keep on coming up with new stuff, new stuff, new stuff. Prime example is when my father-in-law was still alive, he ended up hurting his elbow. He was at the time 76. He fell, got a laceration. We dressed it all up because the guy called to the house, Didi, you're a nurse, can you help him? Of course. Went and dressed him up and said, okay, Pop, take this off in 24 hours and wash it really good, and then keep your dressing changes. My mother-in-law wasn't home at the time. She was taking care of my sister-in-law recovering from surgery. 3 days later, he was like, well, you went to the doctor? Oh, you did, it was 24 hours later, we went to the doctor. The doctor's like, oh, your daughter-in-law's a nurse. We don't have to look at it. I'm sure it's fine. Here is an injection of penicillin. Here's some amoxicillin and go on about your business. 3 days later, so 72 hours after the first dressing, never went back to check on him because he was a stubborn man anyway. He ended up in the hospital with IV antibiotics because the penicillin didn't kick the cootie that was there, even though I washed it and did all that kind of stuff. Plus, he was a diabetic. So he ended up getting IV antibacterials then to treat after they cultured and sensitivity in. So, long and short of the story is penicillin with older adults, that cootie's resistant to it. And so can that patient be. Hence the whole thing about the resistance when we were talking about immunity and stuff. Yes, Jessica?
If they're resistant to the penicillin, are the chances of them being resistant to the, you said, cephal and the beta lactase, the other family members?
Yes.
Tied to?
Yes.
The whole category?
The whole category, yep. Yeah, because these have been around for the longest times. I mean, back in the day, made in a refrigerator. You know, that whole, we thought it was kind of funny, like, oh, bacteria grows in a, every time you pull like moldy bread out, you're like, look, I'm making penicillin. Because you're kind of actually. So, with the spores. Anyway, so these are IV. One thing that is helpful that the cootie is not resistant to penicillin is any tooth decay. Tooth decay probably is one of the fewer of the bacteria causing infection with the tooth decay that these penicillins would work for. It's a milky IM injection, and it still does the trick because that bacteria is not resistant to it. However, we're not thinking older adults. We're saying in general. Older adults probably won't, still going to go to that whole overexposure and things like that. So the broad spectrum penicillins, that's where your amoxicillin comes in. Again, it's a cillin, so it's in the family. Ampicillin, amoxicillin. All of you have had amoxicillin. You had an earache when you were little, and it was in the refrigerator, and it was pink. Right? And you
delicious.
It was not delicious.
It is delicious. I could drink a bottle of it.
Oh, disgusting. Okay. First of all, I hated it because it was pink and I was 15. So I was like, oh no, I gotta drink this crap. No, Mom, I don't want to. But everybody's had it if you've had an ear infection when you were little. But keep in mind, you were exposed. How many times did you have an ear infection? How many times did you have that pink stuff? Right? So now, probably not going to do much for you. It could, depending on how much exposure you've had to it. But again, got to think about that whole resistance. Bactericidal, that's why it's good. It's because it kills the bacteria instead of just inhibits the growth. Okay? Then we have our declapocillin, which is your resistant to penicillin. Staphylococcal is the one. Again, bactericidal. So as we go on, who is resistant to penicillin, as you see these subclasses, then become a little bit stronger. Extended spectrum, that treats more bone, skin, soft tissue, respiratory. It also says UTI. As we go along in these anti-infective discussion, there's even better stuff. They won't even, I'm not going to say waste their time, but I'm going to say waste your time. With the penicillin family, they're going to go to the bigger ones that are out there for specific UTIs, and then respiratory tract. Cytals, and then they're here, Tycar, which is ticarcillin, and then your piperacillin. So again, you'll recognize the cillins because they end in suffix of cillins. Here is beta lactase inhibitors, not given alone. So this is combined with the penicillinous sensitive penicillins. So when I said earlier about clav acid, this is the one I was talking about. Your augmentin is your clav acid with amoxicillin in that combination drug. If you've ever had augmentin, you know it's a horse pill, right? People, you can squirt it, it's broke, you take half and half. But this is for that is not given alone, so it enhances that effect of it. So there's your augmentin we talked about. This is a fancy way to say the clav acid. Okay? And then you have the piper and the tazobactam. The reason I want to point out this particular one with piperacillin and tazobactam as a combination is Zosyn is a medication or antibacterial that is used a lot with pre-op. When patients are going down to surgery and they call and ask, go ahead and give that pre-op antibacterial, I would bet 99.9% of the time, and I'm not a betting woman, is that is the drug of choice. They have found that by giving that antibacterial ahead of time, or any antibacterial ahead of time, right before surgery, within that 30-minute window before the patient comes down, blah, blah, blah. It's to cut down from post-surgical infections. So being that it's a broad spectrum, it covers anything that can happen from that moment on. So, nursing interventions, or things that we have to consider. Anytime you see CNS when you're looking at this later, is your culture and sensitivity. So again, they culture and they find out what that bacterial or that cootie is resistant to as far as antibacterial goes. Penicillin also we have to monitor patients in the penicillin family as a whole. So everything that we've talked about, we have to monitor them for bleeding because as the penicillin family does, it suppresses or decreases the platelet aggregation. So it acts on the platelets to make them more susceptible. It's important to monitor closely during the first dose, and the reason why is if the patient's going to have a reaction, they're going to have it when they started that first dose. It's not going to be 3 days from now. It's going to be initially. They swallow the pill, they start getting scratchy, or hives, or whatever the case may be. Hopefully not full-blown anaphylactic shock, but it could happen. Increased fluids. You will see in all of these that we're going to talk about with the anti-infectives, you're always going to see CNS, and you're always going to see increased fluids. That is to help those kidneys. Remember, we said when we started this about organ toxicity, we said liver, kidneys, and ear, right? So by helping flushing that out of the system with that water, they recommend a full glass by taking. Take 1 hour before or after meals, because we already know, right? Food decreases absorption. So the rule of thumb you're going to see across the board is take 1 hour before or 2 hours after a meal. By then, the food has passed, or the food won't get in the way at all. Now, with that said, the only one that we've mentioned today so far that can be taken with food is amoxicillin. So usually when the kids said, oh, this is so gross, let me have a drink of pop, or let me have some applesauce or pudding or whatever. Oh, excuse me. When our parents or caregivers did that for us, they were actually doing okay. But if it wasn't okay with food, then absorption would have been decreased. Super infections, we talked about, of course, safety measures. So that's self-explanatory there. So a cousin or a relative, however way you want to look at it, is your cephalosporins. Your cephalosporins is made up of, guess what? Beta-lactam structure. Yes?
Oh, I'm sorry. So amoxicillin is the only one that you can't take with food. Is that included
You
augmentin?
should take with
Oh,
food.
you should. I'm sorry. Is that the same for augmentin then too?
It's controversial because of the clav acid. I honestly don't know 100%. I would say it should be okay, but we'd have to look that up and find out for sure.
Pharmacy label products that you may or may not.
May or may not is your answer from our farm tech in the room. Okay, so cephalosporins, beta-lactam structure. Again, when patients allergic to penicillin, could be a great possibility they're allergic to the cephalosporins. It's made up from a spore, so that has the whole mold idea, right? Mold, green, black, white stuff, furry. It's usually furry on your bread, right? So Cytos treats a whole bunch of stuff. Genitalia infections, and then the rest of them. And the reason I pointed that out specifically is because I'll tell you why in a second. Generation of cephalosporins. So as we know, each generation, they think they were growing bigger and better, okay? Which in turn they kind of were. So initially the first generations were just PO. And if you remember when we talked about Keflex, remember when we were talking about half-life and who had Keflex, and some of you raised your hand and you took it more often? So these tell you that these are a short half-life, taken more frequently. So PO, right? Remember that discussion when we first started this whole mess, when we talked half-lives? Nods of heads, yes, good, 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 good. Now, I want to point something else out. If you notice, it's not a suffix in these cephalosporins. Where can you see? Okay, so I mean, you're saying I'm short, you can see. Cephalosporin-wise, if you notice, this prefix is CEPH, right? If you notice, as we move along, it's CEF, CEF, CEF. notice Keflex is generic name is CEPH. Must be pretty old, right? Because they didn't come up with any others, so they gave it enough because they thought, oh, one less letter would be better. Okay? So just to point that out, it's a prefix and not a suffix for these cephalosporins. Always think of second generation. I always think when I see this with the generic name, because remember, you gotta know the generic, but here in farm, we still do both. Mufoxin. If you think of lidocaine, and you think of mufoxin, because that's what it kind of looks like, even though it's not how it's said, right? Mufoxin, but mufoxin sounds the same. Second generation in the lidocaine. Okay? Think lidocaine, second generation, Simba, that was the whole purpose. You guys need to liven up. Lidocaine is a very happy story. Come on. Never thought in nursing school you taught Disney, but lucky for you, you have me in farm. Because we gotta learn this crap, right? Because it is kind of crappy. Okay. Third generation. Rocephin again, cephalotriaxone. This one is number 1 in the party pack. And I'll explain here in 1 second what the party pack is. You can't see me giggle under my mask. Corey may be able to hear me, but so we call it the party pack when patients are exposed to any kind of sexually transmitted infection. Okay? If it's drainage, color, itching, and any of the genitalia, both male and female, doesn't matter. This is the first of 4 drugs that they get after they have their genitalia cultured in sensitivity with the drainage. So this is an IM injection, 250 milligrams, not important. What is important is, it is horribly stinging, okay? So we already know we reconstitute with sterile water. In this case, we would reconstitute with lidocaine. So as much water as you use the same amount of lidocaine to being a caring and compassionate nurse. They already have problems elsewhere. They don't need problems in the arm or whatever muscle you're going to give it to them in. And so you want to make sure that you are caring and compassionate and reconstituting with lidocaine. Horrible stinging IM injection, it does come. That's my other point to this too. With these first generations were PO, the rest are IM or IV. Mufoxin is IV. Rocephin can be either. And then 4th generation, the cephalpine, or PEM I should say, it's the Maxapine as the trade. Granted, you know the generics. 4th generation, it's the Max. Can't get any further than that as a 4th generation. Okay? So so far we got number 1 drug in our 4 of the party pack. Everybody understand what that means?
Yes.
Okay. Good deal. So we already know here, generations, they treat different stuff. So go on from there. Pharmacology, we said oral IM/IV, we already said that. High dosages can increase the bleeding and nephrotoxicity. So that's one of the reasons why, again, we think about increasing the fluids if we can. Drug interactions listed there for your nursing interventions. Assess renal and liver, which we would anymore, because this is what's pointing out to liver and kidney toxicity. And then high dosages can lead to that liver and kidney toxicity. Superinfection, we already know about the probiotics, yogurt, and buttermilk. And then, of course, always keep out of the reach of, I think that's self-explanatory. So the macrolides. One in particular is erythromycin. When we say erythromycin and ends in myosin, we already know it's going to not be good to the kidneys or to the liver. Maybe this is the one for the ear, maybe not. But it could risk the possibility. The usage are for moderate to severe infections in all these areas that it mentions. You can't go wrong with the side effects of anti-infectives as a whole, as in GI distress. When it has a side effect of tinnitus or ringing in the ears, there's our answer for ear toxicity. Because it always reaches that possibility, because it does end in myosin. So, examples are listed here for you. This last one, azithromycin. This one, erythromax, same thing. That, you know, as a Z-Pak, you guys have taken it, I bet you, a million times. Your infection never went away. You went back to the doctor, they gave you a refill. And that has to do with resistance. So sometimes you need 2 Z-Paks instead of just a 5-day, you need a total of 10. So hopefully, physicians now, more and more often are just doing refills automatically. Because they tell you if it doesn't go away after the 5 days, then go ahead and get another one. And what's interesting about the Z-Pak is you already know, right? The first day you take 2, right? And then, so it's a loading dose for the maintenance dose. It's also number 2 in your party pack drugs. 1 gram PO is what they get to take care of any. So now we're on the number 2 of our party pack. So macrolides as a whole, too, it says azithromycin levels may be reduced by antacids. Good rule of thumb to remember that any medication is reduced with antacids. And when I say reduced, I mean reduction of absorption. So they really recommend kind of the same thing like they do with the food. 1 hour before, 2 hours after. Take the medication 1 hour before an antacid or 2 hours after an antacid. And again, antacids will decrease across the board for a lot of drugs. They point out that one specifically because it is, but it can do it to any of them. So it's a good rule of thumb just to remember that. And then full glass of water, which we already know. The leucoamides, here's your examples. Again, they end in myosin. So the myosins really have a lot of cousins, right? A lot of last name, and you know that from some of the family reunions. They all have the last name, but some do a little bit different, and you know that. Because you have cousins in your family with the same last name, right, that do something different. Some may be a teacher, or nurses, or police officers, or firemen, or whatever. Football players, my favorite. So, okay, make sense? So when we're talking about these leucoamides specifically, what should we know about them? Hold, please. Catch up to myself. GI distress, we already know. That's across the board. One thing here, this pancromium may enhance the neuromuscular blockades. These are 2 black neuromuscular blockades. Pancromium is also known as Pavlon. It's a paralytic. So when a patient is getting emergency intubated, they might paralyze them to intubate. So this particular group of antibacterial may enhance. So in enhancing, they have to have an airway protected. Then it talks about vancomycin. Vancomycin we mentioned when we were talking about peaks and troughs way back when. So the vancomycin world, the usage is serious infections of bone, skin, lower respiratory tract. Serious. Side effects. Red neck or red man syndrome. That's if the IV is way too fast. So, yes, they turn red. The problem with them turning red, face or body, usually upper chest, arms, you see it, is because the blood pressure is dropping. Because that tells you ding, 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 that IV is infusing way too fast. So we have to monitor the blood pressure as a whole. Nephro, definitely toxic to kidneys and could be ear. And then Stevens-Johnson syndrome is a deadly skin disease. It's red rashes with blisters. So they have impaired skin integrity that leads them to death because of their blisters and their skin integrity issues. Because if it's a serious infection, now we just cause them all these blisters. So adverse reaction for that. Oral or IV? IV, if they can tolerate with the kidneys. The oral is actually, can be a suspension, which if they have a G-tube, we put it suspension form or liquid form, and we use it that way. Administer 1 hour, rotate sites if you can, and then we're going to monitor vancomycin levels. Trough, remember the magic number was 20? We draw that trough 1 hour before the next dose. It's usually given every 24 hours. And so 1 hour before, they will draw that trough. So what does that trough tell me again? If I have it above 20, what does that tell me? It tells me to hold the dose, but why? It's still in the system, so it tells me drug accumulation. Because after 24 hours, it should be gone, right? It should have half-lifed it and left and screened it out. Lytolitz, or Lides, however you like to pronounce it. Fairly newer of the drugs, still in the family of the mycin, oral only. Many drug interactions, many, to say the least. That's all I want to point out with that one. Tetracyclines. They end in cycline, is their suffix. Very actions, there are a lot. One biggest thing that tetracycline does is it treats acne. Topical or oral. Now, if you remember way back one of the days of acne, 16, 17, maybe even younger, right? These patients don't want to give them any sooner because it can discolor permanent teeth. So they're not recommended with anybody less than 8 years of age because they are more prone to get their teeth discolored. And you may actually see patients that or people that are walking around with discolored teeth. Not because of poor oral hygiene, it's because they had tetracycline when they were younger. And that's exactly what happened to them. For treating for acne. So they actually tried to do something good, but in turn, stained their teeth with it. One thing, as you notice, short-acting tetracycline, then you have the democlocycline, long-acting doxycycline, and then this is the only one that can be taken with milk or milk products, so it doesn't affect the absorption. Antacids we have to worry about. Biggest drug-to-drug interaction with tetracycline is oral contraceptives. So if teenagers are put on a birth control pill, but they are still sexually active, the birth control may not. There has been many a babies born from tetracycline babies because mom was on tetracycline for acne, and she was also taking birth control, and then they didn't use secondary protection, and here is a tetracycline unwanted child because of that reason. So make sure you educate those patients about the interaction between oral contraceptives and that. So pretty much all the same. Again, avoid milk, iron, and antacids for absorption, but remember, we said one of them, right, can be taken with our milk and milk products, and that was the doxycycline. Aminoglycosides. Aminoglycosides is your myosin again. Now, interesting with gentramycin, that is one that is definitely, we don't even worry about livers or kidneys with them, we worry about ears. Gentra is the ear causing problem. Causes ear toxicity, definitely ototoxicity, however way you'd like to look at that.
Are you saying Genta or Genta?
Gentra, right here. Gentramycin. I always point to pronunciation. I don't claim to be a communication major. So, photosensitivity, superinfection, oto, and then kidneys. Yes, you still worry about them, but definitely ototoxicity is the biggest with this. Then it doesn't get along with the penicillins at all. Same concept. Now, when we're talking about peaks and troughs, we said Vanco was troughish. Our peaks are drawn for gentramycin. So when I say peaks, that is the first drug you think of. Really the only drug, aside from our insulins that we'll talk about way later. We don't have troughs with those. We have unset peaks and duration of actions. Fluoroquinolones. This is for big respiratory, bronchitis, pneumonias. Treats UTI, especially those that are urosepsis. They like our levofloxacin or Levaquin. And then ciprofloxacin they like for UTIs. More urosepsis though is Levaquin. One thing we worry about, however, we already know antacids across the board, but the levofloxacin increases the effects of hypoglycemics. So that means that if I'm lowering a blood sugar, I'm going to even lower it more. So we have to be cautious with this particular drug and anybody who's a diabetic. Theophylline and then caffeine. Caffeine is a stimulant. mixing with the levofloxacin and caffeine will cause even more tachycardia. So we have to keep an eye on those patients with tachycardia. And recommend them not to take caffeine, to avoid it altogether. Would be a great idea. Sulfonamides. One thing about sulfonamides is it's oral IV, topical, and eye, which we haven't seen yet. Oral IV, topical, and eyes. So, short-acting, intermittent-acting, this trimethoprim and sulfamethazole, also known as Bactrim. When somebody gets a UTI, this is one of the common ones. Initially, the first UTI you ever get. They usually use that particular drug to treat. Of course, after, let's hope, culture and sensitivity. GI distress, increasing fluids, monitoring CBC, that's always because of kidneys and liver and all of that. Avoid antacids, we know. The trimethoprim is a urinary tract anti-infective. That's why it's good. And combined with the sulfamethazole, it's a synergistic effect. So it's a combination drug for that UTI. That's why they like it. Same thing here, drug interaction, gotta watch those diabetics and their blood sugar. So there's been 2 so far now we had to watch blood sugar with those patients. Of course, same thing, 1 hour before, 2 hours after. Increased fluid. CBC, there must be some bleeding association with it with platelets. And then having the client avoid direct sunlight, because that makes them more photosensitive. Not the drug, but the patient. Questions about that